Hi everybody, I'm Juan Pablo Costabel from Instituto Cardiovascular de Buenos Aires, and we are here in EuroPCR talking to Gabriel Steg. Thank you, Gabriel Steg. And Gabriel Steg was one of the men who presents in last ACC the result of the Odyssey. Congratulations for that, great study. And in Argentina, we are concerned about, these results were great, and we love the risk of our patients, but we are concerned about prices and economy. So, which would be your idea about the real use in real practice of these drugs, evolocumab and alirocumab?
So, it's a great question. I think we now have evidence from two large trials, Fourier and Odyssey, and in fact also additional evidence from the SPIRE trials, that PCSK9 inhibition produces not only sustained and dramatic LDL reduction, but is associated with cardiovascular benefit. Actually reduces MACE and cardiovascular events, both in patients with stable arterial disease, as in the Fourier trial, or in patients who had an ACS in the past few months or year, as in Odyssey outcomes. And this is true on top of truly maximal statin therapy. In Odyssey outcomes, we insisted on patients receiving maximal statin therapy with 40 to 80 milligrams of atorvastatin or 20 to 40 of rosuvastatin, and most of them actually did get that, and we still got benefits. So I think that's the number one finding. The other finding, major finding, was how safe this is. We had all sorts of prediction that we would have cognitive dysfunction, dementia, suicide, diabetes, intracranial hemorrhage, I mean, you name it. The reality is that the risk-benefit ratio of these drugs is remarkably safe. They were really well tolerated. Granted, this is over a duration of up to 5 years. It's not lifelong, but up to 5 years, so far, so good. We didn't see a signal except for mild local injection site reactions, swelling, itching, redness, which I think we can live with. The problem, as you alluded to, is the cost. Yes. If this was the price of aspirin, we would give it to everybody. But it's clearly not the price of aspirin, so we have to select the best candidates. And I think the best candidates are the patients at the highest risk. And we can identify risk based on a number of features. We know patients with diabetes, patients with peripheral arterial disease. There are a number of clinical features that will put you at high risk that are important aspects. Second aspect is patients with familial hypercholesterolemia, because we know that this is truly a disease of cholesterol intoxication. And here we have something that avoids it, and we can prevent those horrible events in young people that we're seeing with familial hypercholesterolemia. Sometimes you have teenagers having MIs. Now we can prevent that, so I think this would be my second population. And then the broader group would be the high-risk patients in secondary prevention who have uncontrolled LDL. And if we have to start somewhere, I think selecting patients on the basis of uncontrolled LDL on maximal oral therapy would be where I would start. So I would put the patients on maximal statin. I would add ezetimibe, even if we didn't implement ezetimibe in the trial, because ezetimibe is cheap and has some effectiveness. And if their LDL is still high in secondary prevention, despite this maximal statin therapy, these are the patients where I would consider adding a PCSK9. And because risk is proportional to LDL, I would probably start with the highest LDL to start with. Yes. And indeed, in Odyssey outcomes, we saw a greater event rate in the placebo arm for patients who started off with an LDL above 100. And I think this is a very high-risk group. They had a 15% event rate over the duration of the trial. So I would start somewhere there. Whether we want to put the threshold at 100, 130, 160, as it's purely economics, but this is how I would do it. I would select patients, maximum oral therapy, uncontrolled LDL, and high risk based on clinical profile. And I would put the threshold based purely on the economics.
Perfect. Thank you very much, and great summary.
Thank you.